osteomyelitis. Also, I remind you we have discussion, a few minutes for discussion during preparation for the clinical demonstration. So if anybody has a question, you can write it down and prepare it.
First time the course will be documented, and this will be very nice. أخيراً بالنسبة لموضوع المحاضرة البيدياتريك بون اند جوينت انفكشنز يعني الناس ممكن تتساءل طب ما كان الدكتور طارق يكلمنا عن الدي دي اتش، كان يكلمنا عن الايربس بولسي، عن السيربرال بولسي. الحقيقة البون اند جوينت انفكشنز يعني مظلومين احنا ما بنتكلمش عليهم enough، وزي ما هنشوف في المحاضرة late sequelae of acute septic arthritis اللي هي disastrous destruction of the joint والchronic osteomyelitis اللي هي a lifetime morbidity that results from maltreatment of acute osteomyelitis are actually I call them iatrogenic diseases. احنا السبب فيهم because we did not diagnose them correctly and early enough and we did not treat them well. فعشان كده we should give them enough attention. Expected lecture outcomes بتاعتنا to be capable زي ما قلت of early diagnosis of acute septic arthritis and acute hematogenous osteomyelitis in the pediatric age group, to be capable of efficiently treating both conditions, and to be familiar with the severe morbidity that results from missing diagnosis or maltreating either of them. The septic arthritis أنا عايز أخلي المحاضرة شوية more clinically oriented يعني. فهاو does it present in neonates and infants؟ كتير قوي بيكون عندنا history of incubator، بيكون عندنا pseudo paralysis أو absent movement of the whole limb. الديفرنشال diagnosis بتاعنا زي ما كلنا لازم نفتكر should include true paralytic conditions زي obstetric brachial plexus palsy والتروما سواء كانت في الupper limb أو في اللور limb، سواء كانت fractures أو كانت slipped epiphysis، أو الانفكشن سواء كان الأكيوت سيبتيك arthritis اللي احنا بنتكلم عليه أو الاوستيومايلايتس. لأن الاوستيومايلايتس in the proximal part of the bone in metaphysis where it is usually popular can sometimes or very commonly mimics the acute arthritis. في الولاد الأكبر في children who are older the classic picture of the sudden onset of joint pain and swelling. The cardinal sign اللي هي الساين اللي لازم تكون موجودة عشان تشخص اللي هي complete loss of joint movement active and passive. الديفرنشال diagnosis في الهيب افكشن زي ما الدكتور محمود كان كلمنا تداخل في المحاضرات very important عشان أكد المسج. الirritable hip والنون joint causes زي الacute inguinal lymphadenitis والappendicitis. لازم نفرق ما بينهم ان في الاكيد مثلا inguinal lymphadenitis والappendicitis الفليكشن on the extension of the joint is painful and is limited، ولكن the rotation of the joint the external and internal rotation is totally intact and is pain free. في حين ان في حالات septic arthritis all joints are affected particularly rotation. طب what are the investigations زي ما الدكتور محمود كان بيكلمنا التولز او الارمنتاريوم that we have؟ اللابوراتوري زي الليكوسايتوزس، الاليفيتد دي اس ار اند سي ار بي، البلين اكس راي، الالتراساوند، and finally the tissue diagnosis اللي هو الاسبيريشن اوف ذا جوينت. السلايد دي is very important عشان هنرجع لها حالا. How to treat؟ We should always remember that acute septic arthritis is a surgical emergency that needs emergency arthrotomy, and then we should give antibiotics. Antibiotics should be given. The type should be given according to the culture and sensitivity. The route, it should always be given parenteral, IV. The duration, it should always be given for a minimum of 3 weeks, 1 week after normalization of the CRP زي ما هنقول, and CRP is the best monitor to the response of treatment. Now, what is the relation between acute septic arthritis and acute hematogenous osteomyelitis? In infants and up to 18 months, the metaphyseal vessels, branches from the nutrient artery, will cross the physis or the growth plate. These vessels remain open until the age of 18 months. عشان كده up to the age of 18 months, infection from the proximal metaphysis can spread into the epiphysis, resulting in septic epiphysitis and arthritis. In older children, these vessels will close, and the physis becomes a barrier to the spread of infection, and there is a separate blood supply to the metaphysis and the epiphysis. That the joint will only be affected if the metaphysis is partially intracapsular. زي ما بيحصل في البروximal femur وزي ما بيحصل في البروximal humerus. And actually, from a practical point of view, the proximal femur with proximal humerus osteomyelitis can always result in septic arthritis regardless of the age. For infants up to the age of 18 months, عشان the fact of the open vessels, or above the age of 18 months, عشان the fact that it is intracapsular. The case presentation is very interesting. Yeah, it's from one of my patients, a male baby, born 37 weeks. He was placed in the incubator 8 days because of immature lungs. لما خرج من الانكيوبيتر جاله chest infection وخد IV antibiotics وكان discharged بريزيديوال chest infection ومدينه IM antibiotics. في غلطات كتيرة هنا من ضمنها ال IM antibiotics. المهم بعد أسبوع the parents noted that the baby was reluctant to move the whole upper limb. They had a picture of pseudoparalysis. وهم قالوا ان they described it as being paralyzed. كأن دراعه مشلول يا دكتور. هم they used this term which we use to describe the condition. But the parents seek medical advice elsewhere. The baby was examined and an X-ray was taken اللي احنا شايفينها. للأسف the child was diagnosed as a sprain of the shoulder وطبعا مفيش حاجة اسمها كده. No treatment was given. بعد كمان يوم راحوا لانذر دكتور. اكشلي الدكتور ده شخص ان شولدر ديسلوكيشن موجود والدكتور ده عمل ريدكشن اوف ذا ديسلوكيشن. كان كله حاطه in brackets and it is medically incorrect. بعد كمان يوم من this so-called reduction, the parents noticed that the shoulder became more swollen, hot, and any attempt to move it was extremely painful. At that time, when I examined the baby, the shoulder was swollen. The child did not move the whole limb at all. بس حطيتش فيديوز عشان الوقت. Any attempt to move the limb was very painful. طيب, plain X-ray ادتني الصورة دهيت. What is the next step? يعني اليوجوال براكتس زي ما كنا بنقول قبل كده، كان الدكتور محمود بيتكلمنا عن الالتراساوند. طب اوردر ان التراساوند. التراساوند طلع لي سليب بروكسيمال هيومر ابيفيسيس اللي احنا كنا شايفينها في الصورة. ولكن no effusion. طيب انا بقيت محتار ان الكلينيكال بيكتشر اللي احنا شفناها الهيدنس والهوتنس والتوتال inability to move the limb كلها pressing in favor of acute septic arthritis or acute hematogenous osteomyelitis of the proximal humerus. The history of examination very typical of this. طيب should we trust the ultrasound? Now we all know that ultrasound is operator independent. And the person who does the ultrasound is the only one who can give us correct information. دكتور محمود ورانا الصور احنا برضه we can have a look ولكن sometimes the transducer is not placed correctly and that's why sometimes the pictures that are sent with the report are not very accurate. طيب. But as we all know, a good doctor you should have a high index of clinical suspicion. But we had a high index of clinical suspicion for septic arthritis. فعشان كده بقى we have other investigations that we should not forget. The lab investigations are very important. وهنسمع بعد كده حالا ان they are even more important than ultrasound in diagnosis of septic arthritis. So we all believe in ultrasound to diagnose septic arthritis or acute osteomyelitis. You should have ultrasound, you should have MRI, you should have all these fancy examinations. But the lab is very important. لقينا التوتال ليكوسيتيك كاونت 20,000، السي ار بي 175 والاي اس ار 120. For medical legal purposes, we did another ultrasound performed by another radiologist that we trust. فطلع علينا thick massive effusion with fluid echogenicity suggestive of pus plus the sleep epiphysis اللي كانت موجوده. هنا كان في two diagnoses: الانفكشن اللي developed من التيبيكال history of incubator، وطبعا السليب epiphysis اللي اتعملت من ال so called attempt of reduction. كويس؟ طب الديسيجن we all know the answer: urgent arthrotomy. Intraoperative thick inspissated pus was found in the joint, but drill holes were done in the proximal humeral metaphysis, pus came out. مع النظريه بتاعتنا in both are linked in the neonates and in infants up to the age of 18 months. Cultural sensitivity revealed the organism بقى Pseudomonas sensitive only to Tynam. دي بقى very important. A central line was inserted and the baby received IV Tynam for 21 days. But you should never give the child in septic arthritis or acute osteomyelitis oral antibiotics. You should never give the child high-M antibiotics. To keep giving high-M injections for 21 days is impossible. You might cause the child sciatic nerve injury, which we have seen so many times, all of us. And you cannot give IV antibiotics peripherally, sometimes in the newborn, because you sometimes cannot have access to the cannula for several days, but the best is to insert a central line. It is very safe. It should be a usual practice, the management of septic arthritis in neonates and young babies. Monitoring زي ما اتفقنا السي ار بي عشان جبنا the correct antibiotic, we gave the correct antibiotic according to cultural sensitivity, but the CRP decreased after 1 week. فاكرين from 175 less than 48, 22 after another week to less than 6 weeks at the end of the 3-week period of IV antibiotics. As no oral Tynam is available, Tynam is only available as IV, but IV Tynam was continued for another week after the CRP was under 6. And actually, during our monitoring, the child began to move the limb at 14 days post-operative. That clinical monitoring, well, it can be lab monitoring is important to know when to stop the antibiotics. But the minimum is 21 days of IV antibiotics. وده يعني الفولو اب بتاعه. طبعا السيفير رياكشن ده من السليب ابيفيسيس اللي كان موجود، ومن شويه الاكيوت اوستيومايلايتس اللي كانت موجوده لكن اتلحقت ايرلي. وات 1 year ده المنظر very minimal limb discrepancy with a full function of the shoulder. بنرجع بقى لحاجه اسمها الكوكر كرايتيريا، دي الدكتور محمود اتاكد مني انا هقولها في المحاضره الحقيقه اتس انترستنج، ولكن ما تنسوش ان دي اتقالت بس for the painful hip. احنا we sometimes have septic arthritis in the shoulder. For you non-weight bearing on the affected side, fever, ESR above 40 وtotal extent count above 12. لو عندي 4 out of these criteria يبقى عندي 99% chance of septic arthritis، ولو عندي 1 of this criteria عندي 3% chance of septic arthritis. But still you cannot risk leaving child with 1% chance of septic arthritis to develop chronic septic arthritis with the late sequelae with total destruction of the joint. But sometimes even if you open or you do an arthrotomy on suspicion and the arthrotomy is negative, you are still the winner rather than leaving this 1% of the babies with septic arthritis and not diagnosing them. I would rather open this child and have a negative aspiration, a negative arthrotomy, rather than missing this child. ليه ما اتكلمتش عن الاسبيريشن؟ طبعا الاسبيريشن we can do in the knee joint، وطبعا it is essential. ولكن sometimes in the hip it is very difficult to aspirate the hip of a child except under anesthesia. Sometimes the access of the hip joint is very difficult, but sometimes it is always necessary. And from the practical point of view, you have to proceed directly to the arthrotomy as we mentioned. So what is the outcome of untreated septic arthritis? زي ما قلنا هي septic arthritis which is irreversible with complete destruction of the joint. مش هنتكلم بقى عن التايبس بتاعتها وكده عشان this beyond the time and scope of this lecture. The outcome depends on the age and the onset of the disease. An infecting organism هل هو Pseudomonas ولا Klebsiella ولا MRSA ولا Strep ولا Staph. Timing and adequacy of the surgical, and when did you do the arthrotomy? Within the first 12 hours, 24 hours, 48 hours, or after 1 week and after the joint is dislocated and the cartilage affected. And the pharmacologic treatment, did we give oral antibiotics, did we do cultural sensitivity? And I have seen children who have had arthrotomy of the joint to treat acute septic arthritis within 12 hours. and have had very bad outcome because unfortunately the doctor who did the arthrotomy only cared about the arthrotomy. He did not do culture and sensitivity, he gave oral antibiotics, and these are totally against the correct practice of management of acute septic arthritis. Septic arthritis is a surgical emergency that necessitates urgent arthrotomy and requires correct antibiotic treatment according to culture and sensitivity, given IV and for at least 3 weeks and 1 week after normalization of your CRP. Acute hematogenous osteomyelitis, the sister of acute septic arthritis. We have to remember that it is almost a disease of children. Actually, when adults are affected, it is usually because of defective immunity. And it is usually, in adults, when they get osteomyelitis, it is usually not hematogenous, as we shall see. Trauma may precipitate the pathology by causing a hematoma at the site of the trauma. The typical scenario gets usually positive history of direct trauma, whether بيلعب كورة اتخبط في الخط التيبيا بتاعته وهو بيلعب. Within 12 to 24 hours of this trauma, he develops a painful limb, again, painful limb, fever, and is tender all over the limb, not just over the site of the trauma. Acute phase reactants بتاعته تبقى positive. An X-ray is normal and it will only be positive after as early as 10 to 14 days in the best scenario. Causative organisms, we have to remember, طبعا the Staph aureus by far is the most common. ولكن في النيونيتس والinfants, sometimes the streptococcus. في children under the age of 4, sometimes the Haemophilus influenza B. وفي sickle cell anemia patients بيبقى عندهم salmonella. في sickle cell, as we know, we will have the confusion of differentiating between sickle cell crisis and osteomyelitis, as we shall see soon. كلمة صغيرة عن الباثولوجي. طبعا عارفين ان in childhood bacteremia is very common. It is a consequence of other infections في البودي زي otitis media, زي pharyngitis, زي sinusitis, حاجات very common for children. It could be related to daily activities زي simple thing as toothbrushing أو البلزالفا type maneuvers. child بيعطس, child بيحزق, أي حاجة من الحاجات دي تعمل البكتيريميا. دي الانفكشن بتسافر في الميتافيز ليه بقى؟ عشان peculiar vascular pattern كلنا عارفينها ان internal branches of the nutrient artery بتعمل اللي هي ايه؟ الهير بين لوبس قبل ما تعمل الساينوسويدال تخش في الساينوسويدال فينز فيبقى في relative vascular stasis. في الشيلدرن في جابس في الاندوثيليوم of the metaphyseal vessels بتخلي البكتيريا to pass out of the circulation into the extravascular space, and it is these anatomic features that differ from adults وبتخلي acute hematogenous osteomyelitis almost exclusively a disease of childhood. In the different stages, we have to remember that acute hematogenous osteomyelitis is simply starts as cellulitis ولكن in the medulla. تمام؟ عشان كده اسمها osteomyelitis. بعد كده يحصل الابسس formation inside the bone and also subperiosteal. بعد كده يحصل النيكروزز، بعد كده يحصل النيو bone formation. في different age group النيونيتس يبقى عندهم برضه history of incubator. عندهم البريوستيوم loosely applied to the cortex فبيallow the pus to extend over the whole length of the bone زي ما شفنا في الشارت بتاع الشولدر. ما ننساش بقى ان 40% of children will have multiple sites of involvement ودي برضه ممكن نلاقيها في acute septic arthritis and it might affect more than one joint. This is very important. في الانفنت زي ما قلنا حكايه الميتافيزيال فيسلز دي قلناها عشان ما نضيعش فيها وقت. اللاب findings, leukocytosis or acute phase reactants. It's very important to take blood cultures before you start the antibiotics. وطبعا if you can aspirate pus by your spinal needle من subperiosteal abscess أو من المظلة, this is diagnostic. The diagnostic imaging طبعا عارفين ان plain X-ray before the age of 2 weeks is normal, and after 2 weeks هنشوف periosteal elevation. لكن again it is not specific, then you can find similar changes in some other pathology as Ewing sarcoma. Ultrasonography is very important again. We are all now familiar with the importance of ultrasound in septic arthritis. Like we forget that it has an important role in osteomyelitis. Then it can locate the medullary cellulitis, or it can locate the subperiosteal or medullary abscess. We can differentiate between it and cellulitis. زي ما شفنا هنا اهو البريوستيوم is raised اللي هو الارروهيدز الكبيره، الارروهيدز الصغيره في الصوره اللي على الشمال نايمه على العظمه. فهنا في raising of the periosteum وفي subperiosteal abscess. ممكن ناخد منه على طول ايه tissue biopsy. الصوره اللي على اليمين موريه ان البريوستيوم is lying on the bone اللي هي الارروهيدز الموجوده، وان الفلويد كولكشن اللي هو البلاك ايكوجينيستي دوت is cellulitis, it is not osteomyelitis. The MRI can detect the early phases, اللي هي cellulitis. It is again sensitive but not specific. Differential diagnosis will include the cellulitis, will include the acute septic arthritis, the Ewing sarcoma, will sickle cell anemia. Sickle cell anemia, زي ما احنا عارفين, is more common in black people. Will sickling crisis begins at the age of 2 to 3 years. بتعمل bone infarctions. Clinically, it is very similar to acute hematogenous osteomyelitis, and then a sudden attack of pain. زي ما شايفين اهو, fever والbone pain والإريثيما والswelling موجودين في الاثنين. ESR elevated والCRP والleukocytosis موجودين في الاثنين. والX-ray findings might be similar. فطبعا we differentiate by the fact that sickling crises are 50 times more common. يعني I think logic in the child اللي عنده sickle cell anemia more common ان هو يجيله sickling crisis. Ultrasound can detect the subperiosteal abscess. MRI can detect the marrow edema والbone infarct. البون سكان طبعا ممكن تفرق لي ما بين الهوت سبوت بتاع الاوستيومايلايتس او الكولد سبوت بتاع الانفاركشن في السيكل سيل ديزيز. طبعا aspiration of pus will confirm the diagnosis. To diagnose acute hematogenous osteomyelitis, 2 of the following should be present. Pus on aspiration, positive bacterial cultures in the bone or the blood, presence of the classic signs and symptoms, with diagnostic imaging typical of osteomyelitis. We have to remember that histopathology and microbiological examination of bone is the gold standard for diagnosing osteomyelitis. Several times, children with Ewing sarcoma have been trained thinking that they have osteomyelitis and other way around. That is very important. When you take the tissue, you ask for both histopathology and culture and sensitivity of aerobic and anaerobic organisms. In treatment, once osteomyelitis is suspected, the child should be hospitalized, blood cultures taken, and immediate treatment started. Supportive treatment, split the joint to rest and prevent contracture. Antibiotics should be given parenterally, who start empirically and then according to culture and sensitivity, who continue till 1 week after the CRP returns to normal. وفي ناس بتقول continue with oral therapy for another 3 weeks, ولكن the minimum is after returning of the CRP to normal with 1 week. The drainage, low indications for acute hematogenous osteomyelitis. The clinical features and the CRP don't improve within 36 hours. لو الالتراساوند او الMRI already قال لك ان انت في stage of abscess formation سواء intraosseous او subperiosteal, او قدرت انت تعمل aspiration of pus from the subperiosteal abscess. Early and correct treatment, زي ما قلت لكم, cures the condition by arresting the disease قبل ما السيكوسترا, which is the hallmark of chronic disease, develops and prevents development of chronic osteomyelitis, which is a lifetime problem. في طبعا مقولة بتقول ان once osteomyelitis, always osteomyelitis. منظر اللي احنا مش عايزين التشايلد بتاعنا او يعني البيشنت بتاعنا يوصل له يبقى عنده السيكوسترم والكلواكا والانفولاكر. يعني محضر كده سؤالين عشان نفتكر مع بعض. The outcome of septic arthritis depends on all the following except. طبعا لو بصيت نفتكر احنا قلنا كل الحاجات دي معانا غير بس حاجه زي ethnic origin of the patient. Typical scenario in a 15-year-old girl presented to the casualty and has spontaneous effusion of the knee. لما فحصناها ان the knee was warm and tender and there was absolute limitation of all movements. يعني بنقول ان في acute septic arthritis. But the immediate next step in the management of this child هتبقى كله غلط طبعا, ولكن aspirate the joint for microbiological and cytological studies is طبعا the key management step. 8-year-old boy with the typical scenario of osteomyelitis. Like 12 hours previously had been kicked in that leg while playing football. On examination, he was pyrexia, was tender all over the tibia. The correct management would include all of the following except الحاجة الوحيدة اللي غلط طبعا هي of prescribed oral antibiotics and sent him home. ودي بركز على كتير قوي. بشوف junior doctors منكم بيعملوا كده. يعني الchild عنده green stick fracture في الديستال راديوس هنقل ندخله عشان نعمله close the tاني يوم. والchild اللي عنده acute osteomyelitis ادينا له oral antibiotics وروحنا. This is correct and this is not correct. Finally, ذكركم بالtake home messages بتاعتنا ان consider acute septic arthritis or acute hematogenous osteomyelitis in any baby admitted to an incubator. Consider acute septic arthritis or acute hematogenous osteomyelitis in any baby with pseudoparalysis of the limb. You have to remember that acute hematogenous osteomyelitis is a medical emergency that necessitates hospitalization and parenteral antibiotics. Should not send the child home. Acute septic arthritis is a surgical emergency that necessitates urgent arthrotomy. Parenteral antibiotics IV are given according to culture and sensitivity for at least 3 weeks. The cardinal sign of septic arthritis is complete loss of joint movements. Clinical findings, particularly leukocytosis, elevated CRP, and ESR, بهذا الترتيب, are more important than imaging modalities. Microbiology and histopathology are sometimes necessary to confirm the diagnosis. Thank you very much.
الحقيقه هنشكر الدكتور طارق على المحاضره الجميله ديت. الحقيقه سيبتك ارثرايتس والاوستيومايلايتس دول يعني ما فيهمش نظام. يعني المشكله اللي بتحصل زي ما الدكتور طارق وضح كده permanent problem. فتشخيصها بدري مهم، proper treatment مهم، مش مسموح للخطأ في حاجه زي كده. هنشوف